Today's topic is social emotional development in young children, when to be concerned. And we have a special guest for this Provider Academy. She is a clinical director, interim program manager of early intervention services at UCSF Benioff Children's Hospital, and the co-director of Infancy and Early Childhood Mental Health Consortium through the UCSF Department of Psychiatry. So please welcome Dr. Barbara Ivins. And I'll hand it over to you, Barbara.
Thank you, Dr. Roy, and welcome everyone. I am really happy to see some familiar names and faces here. I'm glad to see you back today. I am really happy to be with you talking about this topic. I am going to very quickly share a PowerPoint with you and get started. We have an hour on a topic that is very near and dear to me, so it's hard for me to do this in a short amount of time. But the request that I have from you is to think about social emotional development and when we should be concerned about it. And so that's what I'm going to do today. I realize too that I'm probably preaching to a choir a little bit, and I'm going to be telling you some things that you already know. But as someone who has heard these things myself many times and for many years, they're just so essential and foundational and important that it always helps us to slow down and really think about social emotional development and relationships. So our goals and objectives for today, and the short version of this is that development unfolds in an interpersonal context, so that relationships are not only the focus of our work, but the vehicle through which we provide our interventions. So all things relational, and we're going to think very much about our own relationships as we spend time together this morning. So we'll be thinking about why we focus on social emotional development. I'm going to include something about the role of screeners because we're all using them, and I want to make some comments on that. Remind us how we know things are going well, and then flip to some ideas about when to be concerned. Reminder that all behavior is communication, and really slow us down to think about what behavior means and what relationship concerns look like, both from the parent-child perspective, and then what to do. So I want to start by asking everybody, I'm going to take 30 seconds, ask you to slow down, close your eyes, and think back to a relationship when you were young that was very important to you. So take a moment to come into the room and think of an adult who was an important person to you when you were a young child. Maybe this was a parent or a relative or another family member, a teacher, another adult, neighbor, childcare provider, but just see if you can think about that one person. And when you have that person in mind, take a moment to think about how you felt when you were with this person, or how your relationship with this person made you feel. So notice whatever images or words or feelings come into mind when you think of that relationship. And just take a moment to settle into that, this important relationship made you feel. And then take a moment to think about how it feels to think of that person now. And maybe you feel differently in your body or in your mind. There may be areas of tension or calmness or sadness, or even a bit of loss if that person is no longer with you, or a sense of peace or happiness. It doesn't matter what the feelings are, just notice them. And what I want you to do, the reason I'm starting this morning is that I want you to just think for this moment as we start thinking about social emotional development, of reminding ourselves to kind of slow down and think of the importance of relationships in our lives and how early relationships can affect us even today as we kind of bring them forward in our feelings. So come back into the room, and I'm hoping that you will carry that relationship with you as we think about relationships as we go forward, that we've all been affected and impacted by early relationships, and we are seeing parents and children when those relationships now are being formed. So these are two of my favorite quotes that are coming from across time. And from a while ago, Donald Winnicott was a pediatrician and a psychoanalyst. And he made this very famous quote, "There is no such thing as a baby. There is a baby and someone." And a reminder that babies do not come into our lives alone. They are always with a caregiver or another relationship. And then from Neurons to Neighborhoods, which was published in the year 2000 and was a review of the scientific evidence at the time for early childhood and what was going on, human relationships and the effects of relationships on relationships are the building blocks of healthy development. And these are kind of my core tenets because both of them really speak to the importance of a kind of relational aspect as we think about early childhood development. So here are ways that people have used this term. Early relational health is used by the medical community now. David Willis has really used this term. And, you know, the emphasis on early relationships, I'm going to give you a little bit of history in a moment, but brains are experience dependent, and experience literally shapes our brain. So we think of the early years as this period, a sensitive period for development, and it's why it feels so important. So David Willis has coined this term, which I like, early relational health, and we're hearing it more and more in pediatric settings. Early relational health is the state of emotional well-being that grows from the positive emotional connection between babies, toddlers, and their parents when they experience safe, stable, and nurturing relationships with each other. Early relational health is foundational to children's healthy growth and development and a parent's sense of competence, connection, and overall well-being. These resilient and enduring relationships also help to protect the family from the harmful effects of stress. So the importance of this is in the medical community, there's now an emphasis on making early relational health the core of a pediatric practice. What am I doing to really support relationships? And again, these are all ways of a kind of terminology of thinking about what we might think of as social emotional health. So I like this slide from the early relational health people because you can see this overlap between physical health or the biology, genetic prenatal factors that say that a child may bring, and developmental health, including context, social, economics, education, community involvement, and early relational health, the relationships, attachment patterns that children form with their caregivers. And all of these are in that context. I particularly love that little picture on the right of the caregiver brain and the baby brain and how they absolutely affect each other. So this context of relational health being a foundation in which development unfolds is really, really vital to what we do. So here's the definition of infant and early childhood mental health put forth by 0 to 3. The young child's capacity to experience, regulate, and express emotions, form close and secure relationships, and explore the environment and learn. And so I've highlighted that in blue, that kind of exploration, regulation, forming relationships with others, and learning. All of these capacities will best be accomplished within the context of the caregiving environment. That includes those relational health environments, that includes family, community, and cultural expectations for young children. Developing these capacities is synonymous with healthy social and emotional development. The early childhood mental health field has a problem with this term, early childhood mental health, because we often tend to think of mental health from the kind of pathology side rather than the wellness side. So it's important that this has been really defined in terms of social emotional well-being. And then at the bottom, I've extracted from all of these the definitions that I kind of like, the ones that we use, which are a little bit of shorthand, that early childhood mental health is really the thoughts, feelings, and expectations one develops about oneself, and the thoughts, feelings, and expectations one develops towards others and the world. So in the shorthand version, it's really all about that. So here's my 1 minute historical roots slide. And what you will see on here are some of the people who really started thinking about social emotional development and early relational health, early childhood mental health which really became pretty popular during the World War II era because the impact on children was so great. And there was such a high degree of separation of children from their parents during the war years for all sorts of reasons, children being sent to safer places, children losing their parents, children ending up in orphanages. And you can see the various people who really contributed to this movement, with John Bowlby up at the top right, who brought us attachment theory, and a quote kind of from him. The Robertsons made a series of seminal films about when young children were separated from their parents, starting with this one, a 2-year-old goes to the hospital, where he filmed this little girl in the upper left when she was in the hospital for some procedure for a few weeks, and her parents, at that time, parents were allowed to visit once a week on Sundays and were considered very disruptive. And they wrote a series of papers, Young Children in Brief Separation, when the Robertsons brought children into their own home to foster them when their mothers were in the hospital. And they coined these terms, protest, despair, and detachment, to really chronicle the kinds of behaviors that they saw in young children that were separated. Renee Spitz was a psychiatrist. You can see in the center picture, babies in those isolates. He coined the term anaclitic depression or hospitalism to refer to babies who really stopped growing. And really, he began to think that this was not because there was something initially physically wrong with them, but it had to do with the caregiving that they were receiving, and that within the absence of kind of emotional nurturance and caregiving, the babies literally stopped growing. And that term, non-organic failure to thrive, began to be talked about. And then the very famous experiment in the lower left by Harry Harlow, who did his studies with primates on wire mothers and cloth mothers, thinking that at the time, the idea of a kind of drive theory, that babies really went to their mothers because they fed them. And Harry Harlow's experiments were that the little monkeys would stay with that nurturing cloth mother and just lean over to get their nurturance there. And then just to honor Barry Brazelton at the bottom, who really brought us so much in terms of pediatric care and relational health. So we have a lot of history that really comes through these, I'll call them unfortunate natural experiments, which we're still seeing today in our pandemic, of really, really looking at young children and what we've learned about what they really need in terms of relational health. So I'm going to start with a video, and let me come out of here, and I'm going to show you one of these videos, because I don't think we have time for both. In terms of, you can, oh, good job, Denise. You can see that this is a little boy who has some special needs. He has a hearing impairment. He was born prematurely. He's got a gastrostomy tube. But when I say we're using him as an example of what's going well, what do you see when you see this video? What is it about this that does not worry you and makes you feel pretty good when you see it?
The child is very engaged.
The child is really engaged. Absolutely. Yeah, Katie, I see your hand. Go ahead.
Yeah, he was participating in the feeding, and the parent and the child were communicating to the best of their ability with sign language, and he clearly enjoys and knows that he's ready to eat.
He is seeing himself mirrored in his father's eyes as a competent, capable, visible agent. A sense of agency in the world. I love how the dad has him participate in this feeding. This is not something being done to him, it's being done with him. He's able to use his kind of toddler capacities in a sense of being free and able to really participate with his dad in this feeding. And yes, there's all signing, he's understanding, participating. Thank you guys for the chat. They're in sync, they're in tune. He trusts his caregivers. You're seeing all the things that that you see, that you know, that you recognize when you see something going well, because we see a child who's being treated in this relationship and mirrored in a parent, and learns to kind of expect certain things now from the world. This child who is starting out with some really positive interactions that will allow him to feel capable and competent and visible and safe in the world. Does that make sense to people? So I feel like with this little snippet of watching something for a minute and a half, we start to see all the things that you mentioned here. You're seeing trust, attunement, in sync, responsive, sensitive, connected. Like, you guys are fantastic. You're seeing all the things. So what we know is when we see these, we feel them in our body. Like, I've seen this tape a million times and I still smile, particularly at that moment where the child looks at his dad and is waiting for him to like nod his head, like push the syringe down and put it in there. They're so in sync there, which feels really fantastic. So we know when it's going well, what to look for. So this is a reminder of Stanley Greenspan's version of emotional development. I'm sticking it in here because he was very attentive to thinking of like a stage theory for emotional development. And we see this little guy, if you really look at where he is on here, he is very much in that two-way communicator, cause and effect, doing this serve and return of these circles of communication back and forth with his dad. He's forming a sense of a very competent self. He's solving problems with his dad. He's discovering a world of ideas. Like, we can see something really happening between the two of them and really starting to do that. So I like Stanley Greenspan's version of emotional development as being kind of at the heart of things, and that is just kind of a reminder as we look at him. So when we think of things that are going well, ultimately, you mentioned many of these in the chat, which I love. The indicators of really good social emotional health, the capacity to trust, the capacity to relate, the capacity to take pleasure in ourselves and in others, and the capacity to feel effective and the ability to expect this. That is, we have a sense that the world is a place in which we can feel effective. And even though toddlers and preschoolers can be a challenge at times, that sense of efficacy and agency and exploration are all the indicators and at the heart of what we think of as positive social emotional health. Relationships are bidirectional and transactional. I think we've mostly heard these words. Both infant and the adult are active contributors and they shape each other. That's what we think of as a transaction. We are not the same parents to each of our children because each of our children really pull a different version of our parenting out of us. And despite our best capacity to be similar in our style, we will be affected by that child. And that's as it should be, because we each bring something to kind of shape the other. But the infant is more greatly influenced by the quality of that relationship because they do not have any other experience with which to compare it. So the parent is bringing their past experience and their intergenerational history, both benevolent and adverse, to their relationship to the child. So they are both active contributors, but the baby, again, is far more influenced. For through those interactions, the baby is learning essentially who they will become. The infant and toddler continuously interpret the behavior of the parent or the caregiver as a message about who the child is. So the child's sense of themselves as lovable or charming, engaging, enraging, incompetent, competent is embedded in those transactions between self and caregiver. The child is also learning all those lessons about respect and mutuality and cooperation. And that sense of self and others is really impacted by these relational experiences. So you can see that the child is developing kind of a lens of expectation about the world that starts in these moment-to-moment interactions in early childhood. So parents bring these worries mostly to their experience. Is my baby all right? And am I a good enough parent? And this is particularly influenced by a couple of things. So temperament is one. I want to come out of here for a moment and ask you all to think about temperament in terms of your child and yourself. And I'm going to put this back up for a moment in a second so you can really look at this. Here we go. When you look at this, I want you to think about yourself first. Where are you on this temperament scale? So I borrowed this from the attachment vitamins people. This is an exercise that they use in, I know some of you went through the attachment vitamins training, so you've seen this. Think about yourself first. And we did this in the attachment vitamins training, so this may be a repeat for some of you. Where are you on activity, on new experiences, new people, transitions, or distractibility? So if you kind of mentally mark on this where you might be, and then think of a relationship of somebody now in your life, one of your children, one of your friends, a pet, somebody that you are in contact with a lot. And where are they on these dimensions? And really, when I look at this, I often think of my two children who are grown, but very different. And I can really see that temperamentally, I'm kind of a better match to one of my children than the other. And what does that mean in terms of our kind of moment to moment synchrony and relationships? Who has to do what? What happens if I'm an on the go parent and I have a really calm child who's more reserved or more slow to warm, wants to really take their time to really get used to a situation. And I'm like, go, go, go. You can see how just those temperamental differences could cause some difficulties for us in our kind of relationships, or cause one of us to feel my child who's slower to warm, if I'm always rushing them, may feel like there's something wrong with me. I can't keep up. I can't really do that. Where it may be up to me to slow down and feel like I'm actually moving a little too quickly and I need to really make space for this child. I have a new grandchild who's 5 months old, and he is really helping me see the world through an infant's eyes right now. And he's a very visual child. And he comes into my house and he's really like wide-eyed and looking all around. And it's made me realize that I have a fair amount of color in my house and patterns like rugs or things on the wall. And he's very enthralled with them. And we stop and visit them when he's in the house. Like I stand in front of something on the wall and we just sit and look at it together. And it's really me slowing down and really saying, here's how he's taking in the world right now. And how do I do that? So I want to give you this moment to really think of yourself in a relationship and how we might be thinking with parents about that. So for those of us who work a lot with special needs kids, when children bring special needs to the situation, they can often be, through their developmental differences, confusing partners. They can be under-responsive or over-responsive. They can be easily dysregulated. And you see the picture here of a colicky baby, or a baby who really is having trouble in those first few months with regulation and fussiness. And you can see how easy it is for parents to interpret those signals of the baby in ways that really challenge their own sense of competence or capability. My baby doesn't like to be held. My baby doesn't like to look at me. My baby doesn't eat or sleep well. My baby doesn't respond to his or her name. So this morning I spent some time with public health nurses, and we were thinking a lot about preterm babies. And those babies really are coming into the world before their systems are fully developed and really prone to some of these sensitivities and difficulties with their environment. And the idea of how that affects relational health and how that impacts parents and that transaction between parent and child is what we really want to think about when we think about some concerns in this particular situation with children with individual differences or developmental delays. They're bringing a strong load into the relationship of a challenge for a parent. And the parent, again, who's carrying most of the burden of the relationship, may have to slow themselves down or really remind themselves, it's not that my baby doesn't like to be held. He's a little overstimulated and he does better when I talk to him from the side, or he does better when he gets to take frequent breaks by not looking at me or by pulling away or by being on his own. So we may often be the people in the position to really help parents understand the baby's cues and signals, because we don't want those signals to be misinterpreted by parents and set us down a path of a relationship challenge. So the baby's behavior can affect the parent's responses and sensitivity when they can't figure that out. And we have to really be thinking, where do we locate these difficulties? So I like infant colic as kind of an example because it can be very disorienting if you've heard a baby screaming like that and a parent who's trying really their best to do everything possible and it's not working. It's nobody's fault. This is something we know that the baby will outgrow. They call this the period of purple crying. Purple is an acronym for various things, that it's unpredictable and it happens at certain times. And people don't really understand colic very well, but it's really easy for a parent to take away, there's something wrong with my baby. I need to do something better. I'm not an adequate parent. And then parents have to, of course, always carry the load of other people telling them what to do. Why is your baby crying so much? What's happening? So you can see how something that really is developmental can set parents and their children down this path, a trajectory of something that we might really, really be concerned about later on. So you saw the kind of parents' concerns mostly, is my baby okay? And am I a good enough parent? But I've tried to kind of, as we pivot into thinking of when to be more concerned, to think about what providers' concerns are. And I want to start with this first one. If the parent is worried, pay special attention. So one of those examples of hearing a parent say, my baby doesn't like to be held. In my experience, if a parent is worried, we should pay attention. Parents get a lot of, they have more pediatric visits in the first 2 years than they will have subsequently. I think there's 7 or 9 visits in the first 2 years. And we hear a lot from parents who go into the pediatrician, and pediatricians are often the kind of first responder pool. That's where a parent will go when they have a concern. And they may say, my baby's not talking, or my baby's doing this, or I'm worried about that. And frequently we hear parents report back, oh, well, the pediatrician said, just wait, or don't worry about it, or you were a late talker, or let's wait and look at it in 3 or 4 months. I feel like if a parent is worried, we pay attention, that they know their baby the best. If they're worrying about something, even if developmentally it looks okay, their worry is going to keep them really vigilant. The baby is going to feel that worry. So it's on us to really pay attention when parents bring something to our attention, and creating a space for them to bring that is really, really important too. So if the relationship seems challenged, we're going to look for explanations. Why aren't these two enjoying each other? And this is what we're going to spend a couple of minutes really thinking about now, is what do we look for? What are those red flags, as people call them, to look for? So here are things to notice that can affect relationship quality from the parent behavior point of view. And I'm sure that all of you have seen these or heard these. And what we're always thinking is, okay, now that I've noticed this, what do I do? So let me go through some of these, and you can be thinking a little bit about families that you have seen and when this has come up. So misattributions are when a parent misunderstands or has kind of the wrong explanation for something that they see. They're confused, they're unable to think about it, the baby is confusing for them. And sometimes a baby can trigger a parent's own traumas or early reminders, so their attunement is kind of disrupted. And so then they might hear a gurgle as a growl, like an aggressive growl, or a toddler's natural inclination to kind of take everything, mine, as greedy, or a newly mobile infant's moving off into the world as rejection. So those kinds of misattributions are something that we want to listen for, meaning, okay, is the parent misunderstanding this? How do I understand their misunderstanding? What do I want to do? So you may have heard about it. I have a video, which I won't show you today, of a father interacting with a 3-day-old infant whose hands are fisted, of course, at 3 days. And the father's response to that is to call him a chump and say, see it as a fist who's about to kind of punch him. And this is with a 3-day-old infant. And what we're learning when we hear that is we're hearing a kind of window into the father's own experience and his lens of expectation about the world, and his sense that he's going to need a child who needs to be tough, defend himself, and that that's going to be important to him. But really, that's not why the child's hands are fisted, but it's giving us some information about the parent. Those relationships where we see predominantly what I'm calling negative affective tone, that's when we see constant irritation or negativity or frustration or conflict. Those parents and children don't have a lot of pleasure together, and they don't easily recover from bouts of negative interaction. We don't see a lot of repair after ruptures. And so it could be parental maternal depression showing itself as negative affect, or in the next one, a lack of investment in the relationship. We see a parent who really can't kind of show up and be present. And that's certainly something to kind of worry about. We sometimes see parents who are over controlling or overstimulating. They can't pace themselves or attune to the baby. They're controlling everything as that baby grows up. You think of that little boy Vaughn that we watched, and his father was kind of beautifully scaffolding the interaction, but letting Vaughn be really a part of it, as opposed to somebody who's maybe force feeding a child or really not making space, or their timing is off. So those are ways that we would be worried about that relationship, because it's going to have implications for the child's social emotional development. And then a role reversal is really this idea of expecting a baby to take care of the parent. And usually that's emotionally, like, oh, make mommy feel better. I'm so worried about you. Do that for me. So we want to be careful that that the parent's in the role as the safety protective person, and really not an expectation that the child does that. And then this final kind of goodness of fit, kind of a poor match, what I was talking about with respect to temperament, is really like that. So on the child side, I'm giving you some behaviors that would cause us to be a little concerned for social emotional development and relational health. And these are often what we think of as kind of attachment behavior challenges that we might see. And I want to make sure we understand that sometimes it's confusing to separate out what's a worry behavior from what's something that's normal. So let's take self-endangerment and reckless. These are children, like, think of the children that are eloping from classrooms, that are constantly putting themselves in danger or darting away and having to be chased. So the question that always occurs is, when is a child showing us like motor-driven behavior? And when should we worry about something that looks reckless or endangering as something more like an attachment behavior? The children that are constantly running away from an attachment perspective, it's as if they're saying, chase me, chase me. It's as if they're reminding us that they really haven't had enough of that. They need the parent to demonstrate over and over again that they will come after them. On the other side, we can see a child who shows inhibited exploration, or is really clingy, or really can't explore a new environment. So again, some of that can be temperamental, a slow to warm child, but in its extreme, we have a child who can be really frozen. I saw a child once in a kin care living with his grandmother, and the child was literally frozen. The mother would find him standing there and he would not move. He was so anxious and worried in this household, but when we saw him in his school environment, he was relaxed there and he could really explore his environment and feel better. So the question was, what's happening here? Like, why is this child showing such extremely different behaviors in this household and as a school environment? And it's a reminder always that when you see a behavior, your first response is to be questioning about it, like, what's happening here, as opposed to conclude something about it. We need to see kids in different spaces and different environments with different people to truly understand that. Sometimes a child's behavior can be hyper compliant. They can be too compliant. They can be hyper vigilant. The child who is so good that they're really never exploring their world is another version of this kind of hyper compliance. Why is the child, why are we not seeing some of that typical toddler preschool behavior that's kind of pushing against the rules and doing that? So similarly, the kind of hyper-competent, precocious child. And then I think many of us have seen the socially indiscriminate child, that child where you meet them for the first time and they're on your lap and they say, am I coming home with you? Can I go home with you? That's always a very kind of disturbing experience to go through. So these difficulties can be very relationship specific. And I'm hoping that some of these are familiar to you. This is the circle of security graphic because much of what we've described is on here. If you don't know circle of security, you can find them online. They have some really beautiful videos about their model. They have done this very beautiful job of giving attachment theory to us in this graphic. And you can see that these hands represent this kind of holding environment that the caregiver provides, while we have a child on the top half of the circle who can go out and explore. I need you to support my exploration, watch over me, delight in me. And then on the bottom half of the circle, when things are amiss, the child is sick or tired or frightened, I need you to welcome coming home to me, protect me, comfort me, organize my feelings. So I love the circle, and you can see that many of the behaviors that I just described in the children, you could see as being challenges on the top half or the bottom half of the circle. That reckless, endangered child is having trouble up here. They're out here on the top half of the circle exploring without those hands to come back to, or without really coming back when things are going wrong. And this in the bottom box here, I love what they say. This is their version of how to be a parent in 25 words or less. Always be bigger, stronger, wiser, and kind. Whenever possible, follow my child's lead. Whenever necessary, take charge. So I kind of love the circle of security kind of language for that. So how else do I know to be concerned if a behavior is stronger, lasts longer, is especially disruptive or confusing? Ask, what is the meaning of this behavior? What is it meant to communicate? So this is where I'm going to give you a minute's worth of thinking about screeners. So here is a list of really popular screeners that are used by various child serving systems. I don't know which ones you guys use. I know that in my regional center catchment area, we're now using the DAISY-2 for social emotional screening, but lots of people in early Head Start, pediatrics use the ASQ and the ASQ-SE. We were using the DECA, that's the Devereaux. I'm in mental health, we use the PSC-35. So all of these may be things that you've seen, and maybe the SWIC is a little less familiar to you. I like the SWIC, it's free. It's called the social well-being of young children or youth and children, something like that. It's a kind of composite measure that really thinks about both the family and the child's development. I have a note on here that we do not have a good relational health screener. That has been a problem, probably a good problem, meaning we don't want to judge a relationship based on just a few observations. But what I really want to say about screeners today is that you're going to get my opinion of this, is that screeners should not be used to tell us what to think. We are all kind of in a situation now where we have less time than we've usually had to spend with children and families, or we're not seeing them in person, or if you're a pediatrician, your visits are 12 minutes. And often we use screeners as the first pass of telling us when to be concerned. I think of screeners or assessment measures as tools to hang your observations on, that you should really be thinking, using yourself as the tool, and the screener is something in your toolbox, or the assessment measure, because you are the tool, your observations, you're listening to parents, your interview questions, your hypotheses, you're thinking out loud, you're being curious. Those are the kind of skill sets with which you form an impression about how a child's social emotional health is and how their relationship is going. And these screeners can really help to confirm that or remind you of other things that you really need to ask about. So I think it's important to think of yourself as an important tool, your reflections, and the screener as a scaffold for your hypotheses. It's one way to think about it. So here's how developmentally children show us that something is wrong. I am not telling you anything you don't already know. but I have divided these things into developmentally into infants and then toddlers and preschoolers, because infants show us that things are wrong, usually in a more body-based, biologically based way. There are sensory motor disorganization, the biorhythms, they're not sleeping, they're spitting up, again, intense and prolonged fussiness and crying, they're unresponsive, movement problems. A lot of behavior in the first year of life is motor behavior, eating difficulties, sleeping disorders, elimination problems. So you'll see that infants are behaving, they're showing us with their biological systems when something is wrong. And you will see them get disorganized biologically when they are upset or worried or traumatized in some ways. Toddlers and preschoolers, we start seeing behavior as communication a little differently. We can still see some of those biologically based challenges, but oftentimes we're going to see something that we think of as behavior. Aggression, defiance, you can see that I've put this as kind of fight and flight, internalizing symptoms, fearfulness or withdrawal, self-blame or misattributions. Young children cognitively really don't understand the world the way we do. And so when things are coincident in time, they go together. So we can have toddlers and preschoolers really blaming themselves for big events that cause a lot of stress for them. Difficulty with self-regulation that's developmentally appropriate. You know, can they wait at all? Can they really manage themselves in terms of using a self-regulation and co-regulation strategy? So this is meant to convey that infants, toddlers, and preschoolers can express things in slightly different ways. I'm showing you here the child parent psychotherapy symptom screener, another way for you to see how people categorize difficulties. How do we know when something's going wrong? Well, we see it show up in these very different ways with behavior. And if you guys are interested in these, I can get these into your hands if that would be helpful to you. And then here is another version of this. This is an example of what shows up in the kind of program that I run, which is a mental health program. Our referrals come in usually with these kinds of behaviors. I'm calling these symptoms and causes because you don't know oftentimes which does what for people. So we get a lot of referrals for behavior problems, aggression, doesn't listen, separation anxiety, fears, a lot of children about to be expelled from school because of these kinds of behaviors. We get referrals for developmental capacities that are in question. That can come from an early trauma or an early preterm birth or delay. It can be a child not talking or poor motor control or some of the sensory sensitivities. A lot of regulatory problems, temper tantrums, poor impulse control, hyperactivity. This is when it reaches the level of, okay, we need help. Peer and social difficulties, which can be not interacting with peers, and there's a lot of concerns about autism, or aggression with peers, and then relationship concerns from parents or from other providers who see that. I want to make sure that we put a trauma-informed perspective into our way of thinking, that we can take all of those same behaviors. We work in systems where eligibility is kind of deficit-based or pathology-based. And I want to just put in a pitch for really changing that narrative a little bit and asking about children, not what is wrong with this child or caregiver, but what has happened to this child or caregiver. This is where we start to think more about social determinants of health and the adverse child experiences and the real complexities in people's lives that can lead to a lot of stress that results in some of these difficulties in social emotional development and interactions. And it's very much tied often to what's happened to a child and caregiver. So putting these individual, I didn't realize this was coming in like this. These are all of the different lenses through which one can really view behavior. And we've been thinking a lot, you all think a lot about developmental lenses. We've touched down on individual differences. We've touched down on unmet emotional need, but you can see that behaviors are complicated and that when you see something that is wrong, you stop and you say, okay, how might I understand this in many different ways? And this is another way to really think about it. Like what's going on in your head when you think of a case example? What thoughts and feelings am I bringing to this encounter? What do I observe about this child and their development? What do I notice about how the parent and child are together? What should I be doing and how should I do it? These are kind of the little thought bubbles that maybe are going on in your head when you really think about a child and their parent, their caregiver. And I want you to be thinking like this. If we had more time, I would show you some tapes and we would really go through this together a little bit, slow it down a little bit. But at the moment, what I want to take away, what I want you to take away is when I see something, I'm not concluding, I'm thinking all of these things at the same time. I'm thinking of those lenses, I'm thinking of these thoughts. So what to do and how to do it, I'm going to end with these things because I know that we're coming up on our 1 o'clock time. This is a snippet from the Diversity Informed Tenets that was developed by the Harris Foundation. They are a nice set of tenets to really think about. I am going to look at this one, number 1, 2, 3, 4, 5. Understand that language can hurt or heal. So I'm going to give you an example of what it might look like when we begin to describe or write about a child. So here are two versions of the same child. One describing this, I'm going to read these to you. And this is, again, we are part of what forms a parent or a child's understanding of who they are. So everything we do has to support a kind of the best positive social emotional relationship that a parent or caregiver can have with that child, because it's going to be mirrored to the child who they are. So in the first one, over the last year, Nina's functional progress has been limited. During morning circle time, her responses are very slow. Occasionally, she is able to respond more quickly, but her communications are very short, and we have to work hard to get anything out of the usual from her. Her receptive communication skills haven't improved. Her expressions of excitement can be disruptive in the group. So you can see that that may all be true, but if you're the parent who reads that about their child, what are you taking away about your child? You really take away everything that's wrong with this child. You know, this feeling of she's not doing anything right. It's really difficult for her to make progress. The second one is written a little differently. Nina is always in a good mood and ready to participate in circle time. Her body awareness is improving and she enjoys the freedom and higher level of function during therapy. Nina has reached a point in her life where she seems physically comfortable and happy. She's just mastered jumping with both feet off the ground and she's thrilled about her achievements. Her enthusiasm is beautifully expressed both with her body and her vocalizations. Nina has demonstrated commitment and overall improvement in learning skills. So that's a very different picture of a child and one that a parent can really be proud of. And finally, you will see all of these on the Padlet and you can spend a little more time with them. But those highlighted areas are our ways of thinking how we can create positive social emotional outcomes for infants and children, always enhancing the ability of caregivers to nurture children effectively, focus on strengthening their relationship. We have talked about all of these, including holding hope, which I think is really important. Identify and address developmental and social emotional problems. We will be using the screening and referring and treating. Respond to parents' urgent concerns. Always, always respond to them, acknowledging their states of stress, and work together to create a trauma-informed system of care. And with that, I'm coming out of here because we're at 1 o'clock.